9 waktu WIB. Kalau Wita jam 10.
Oh, Wita, ya, oke.
Ya.
Siap. Oke.
Kalau Dokter Satoshi katanya 5 menit sebelumnya dia join lagi ulang.
Ya, oke. Saya juga. Saya buka dulu acara yang di sini ya. Saya lupa loncat-loncat.
Iya, ya. Kasih Dok.
Baru 5 tahun.
Baru 3 tahun.
Morning, ya.
Jadi maju dikit biar kelihatan.
Gak apa-apa.
Nah,
Ya.
baru kelihatan.
Oke. Iya. Oke.
Dia di Jepang.
Enggak, iya di Jepang ya. Aizah.
Ya, ya Dok.
Dokter Latif nih.
Oh iya Dok, sudah.
Dokter Nakagawa sensei.
Kabar. Halo. Halo.
I can't hear you.
Hello, can you hear me?
Nah, soalnya saya buat ini.
You still have a bit of a technical issue.
Oke. Saya mesti keluarin dulu, remove. Oke. Oke. Do you hear us?
Yes.
Yes, we can hear.
Sensei Nakagawa. Yeah. We used to call you
Satoshi.
we used to call you Satoshi. I'm
Yeah,
sure that
Satoshi is fine. Satoshi is
oh,
fine.
yeah. We're afraid that it is not so polite. Sorry. We used to address it in a Malaysian way. Right. Okay. Looking forward to hear your sharing. Yeah.
Oh, okay, thank you very much.
Yeah. I will send the recording to the child.
Okay. Right.
Okay, right.
Martin.
Sebentar ya, Dok, ya? Ya, okay. Yep. Yeah. 2 minutes more before opening. So, Dr. Aizah, you will be presenting and either present and moderate the
Yeah.
session today.
Okay.
Okay.
So guys, begin now. 1 more minute. Okay. Permission to begin, Doctor?
Yep. Yep. Yeah. Please start. Yeah.
Assalamualaikum warahmatullahi wabarakatuh and good morning everyone. Welcome to the guest lecture today. First, on behalf of Pediatrics Study Program, Hasanuddin University, I would like to say thank you to our speaker today, Dr. Satoshi Nakagawa. It is an honor for us to have you here, and also head of Intensive Care Working Group of Indonesian Pediatric Society, Dr. Riri Fahrina Malaysi, Sp.A. Our topic today is case-based discussion about intractable epilepsy caused by OHTAHARA syndrome. This is a rare case, but the refractory seizure we always find in a daily practice. I hope after this we can learn how to manage if we have a patient with a refractory seizure. Next, I would like to invite Dr. Riri Fahrina Malaysi, Sp.A, to give opening speech.
Thank you very much, Dr. Aizah, for the Assalamualaikum warahmatullahi wabarakatuh. Good morning for our honorary attendee today, our professor, our doctors, and our students and registrar who have joined even today. This is the collaborations between Indonesian Pediatric Society, Pediatric Emergency and Intensive Care Working Group with our...
The voice is not stable. We can't hear you.
You cannot hear my voice?
Okay.
No, we can hear you.
Yeah. Now we can hear you.
Oh, okay. Yeah. Good morning, our honorary attendee and our honorary guest speaker today, our dear professor, doctors, college, and fellow med student and registrar. Today we have our honorary guest speaker to present and to sharing his knowledge about how to manage the refractory seizures in the title of Management of Status Epilepticus caused by OHTAHARA syndrome. And we are very glad and grateful for the acceptance to be our speaker and sharing his knowledge to our members of Indonesian Pediatric Society, especially in Pediatric Emergency and Intensive Care Working Group. And this event is collaborations between us, IPS, and our colleagues from Japan, Pediatric Intensive Care and Critical Care, sorry. And because we are running out of time from our part, we glad and we hope this continuous event educational online to give and enhance and encourage our members and our students to knowledge in our field, pediatric emergency and intensive care, and to reduce the mortality rate in our patients. I think we hope and we do hope the continuity will be and thank you for all of the participants and enjoy the lectures. Thank you very much, Dr. Aizah, for moderate and presented the case.
Okay, thank you, Dr. Riri. The next, we go on the next session. I will present the case about the intractable epilepsy caused by OHTAHARA syndrome. Okay. The slide is can be seen. This is patient identity. This is an 3 months girl. Date of birth is 8 October 2023 and admission date is 26 October 2023. The medical diagnosis is intractable epilepsy, OHTAHARA syndrome, cytomegalovirus infection, and anemia of chronic disease. This is a patient picture. This is a history of history of present illness. This is 18-day-old baby girl was referred to NICU from BG Hospital Kolaka, Southeast Sulawesi, with the diagnosis of neonatal seizure, respiratory distress of the newborn due to bronchopneumonia, and a term baby, appropriate for gestational age. There was seizure since 8 days old of age, generalized seizure continuously, duration until 4 to 6 hours, was not provoked by fever. There was high-pitched cry. No fever, no cough, no shortness of breathing, no vomiting. Pregnancy history, mother age was 39 years old when having pregnant, and this is a second child, regularly controlled to public health center and consume vitamin and blood boosting supplement. No history of hypertension, diabetes mellitus, UTI, and other disease during pregnancy. No history of drug or herbal medicine consumption during pregnancy. Delivery history. This is a spontaneous labor. The baby was at term, immediately cried after birth. Good tone. Apgar scores was 8 in 1 minute and 9 in 5 minutes. Birth weight is 3,300 grams. The birth length is 50 centimeters. Head circumference was unknown. Breastfeeding history. The baby was breastfed since birth until now. There was history of family with the same complaint, her brother, with the same symptoms, and died at age of 1 month due to intracranial hemorrhage. History of being treated in BG hospital for 8 days and treated with ceftazidime and phenobarbital IV. Vital sign is moderately ill, well nourished. Glasgow Coma scale is 15. Heartbeat is 110 beats per minute. Breath is 22 times per minute. Temperature is 36.8 centigrade. And saturation is 98% room air. The anthropometry body weight is 5 kg and body length is 55 centimeter. The head circumference 36 centimeter. There is slightly microcephaly. Arm circumference 9 centimeter. The nutritional status, weight for length is well nourished. Weight for age is normal weight. Length for age is normal status. This is a curve of head circumference. You see, there is macrocephaly. In a physical examination, neurology, in neurology, there is still primitive reflex, and there is pathologic reflex. Babinski was positive. In respiratory, in auscultation is bronchosvesicular, breath sound draws in about lung of the lung, no wheezing. There is normal cardiovascular, normal gastrointestinal, and no spontaneous bleeding. This is a laboratory finding. What we found is the hemoglobin level is low. The thrombocyte is so thrombocytosis. And SGOT and SGPT is at the 10 January is high and 17 January is high in SGPT. The albumin sometimes low, and natrium is slightly low, 134 and until 132. The CRP is increased and procalcitonin also increased. The magnesium level is low when the patient admit, but after that, the magnesium is normal. The CNP, immunoglobulin G, is reactive. Next. This is a peripheral blood smear. The impression is normochromic normocytic anemia suspected caused by chronic disease infection, leukocytosis with a sign of infection. When we care this patient in the PICU, there is a fever, and we perform the culture, and the culture. So from the sputum, this is a sputum culture, is Pseudomonas aeruginosa. And the blood culture show Klebsiella pneumonia. This is radiologic finding. This is MRI without contrast. The impression is normal. Next, this is without contrast. This so we do the MRI CT scan with contrast. The impression was normal also. The EEG in Wahidin hospital show that this is abnormal EEG, discontinuous bass wave, epileptiform activity wave, and there is a burst suppression. We evaluate the EEG again. The abnormal EEG is still persists, discontinuous basic rhythm wave, and epileptic form activity wave. This is a burst suppression. The red one is a burst, and the flat one is a suppression. The working diagnosis is intractable epilepsy, epilepsy syndrome at cause suspected OHTAHARA syndrome, cytomegalovirus infection, and anemia of chronic disease. So the treatment in the PQ is oxygenation via nasal cannula 1 liter per minute, daily fluid requirement by using holiday Sega, aspirin 5 cc per hour intravenously, enteral feeding with breast milk 150 cc per kg, and ciprofloxacin 50 milligram per 12 hours intravena, magnesium sulfate 0.16 ml per millimeter square per hour in 10% dextrose. Midazolam is 200 microgram per kg per hour intravenously, and we give ketamine intravena 2 microgram per kg per minute, and paracetamol if the temperature is more than 38.5. We give also diazepam 0.3 milligram per kg every 8 hours. Diazepam 5 milligram rectally in acute seizure, ketogenic diet, and a history of getting methylprednisolone for 1 month in NICU. This is collaboration patient. So the neurology division give phenobarbital maintenance 8 milligram per kg orally, and phenytoin maintenance 5 milligram per kg every 12 hours orally. Levetiracetam 40 milligram per kg, and valproic acid 20 milligram per kg. From the infection and tropical disease division, he give valganciclovir for CMV for 16 milligram per kg per 12 hours oral. This is a disease course. The patient in 26 October 2023, the baby is referred from BG Hospital with the diagnosis of neonatal seizure, respiratory distress of a newborn due to bronchopneumonia at term baby appropriate to gestational age. The patient in NICU for 53 days with neonatal seizure at causa suspected OHTAHARA syndrome, followed by EEG examination. The seizure is duration is 4 to 6 hours. The therapy is antibiotic, valproic acid, midazolam, phenytoin, and phenobarbital, and methylprednisolone for 1 month. In 21 December, the patient referred to PQ with intractable epilepsy syndrome at causa suspected OHTAHARA syndrome, cytomegalovirus, and anemia. The seizure is still persists 4 to 5 times per day. The duration is 20 to 30 minutes. First, we continue the anti-epileptic drug from the NICU, but the patient, after more than 1 week, the patient is not have improvement. The patient still have seizure. So I think we have to think about another approach for the anti-epileptic drug. So we try to give the N-methyl D-aspartate blocker. So first, we want to give the patient is dextromethorphan, but there is not available. So the patient was treated by magnesium sulfate. At first, the effect is good, no seizure for 2 days. So we moved the patient to high care unit, but the patient have a fever again because of infection from Pseudomonas and Klebsiella, but and we put the patient back to the PQ after 3 days because the patient have a fever and seizure. So we changed the magnesium and then give ketamine and ketogenic diet. After giving the ketamine and ketogenic diet, the seizure is decreased only 1 time a day, and in acute phase we give diazepam rectally. I think this drug is more effective. So after free from seizure 4 days, the parents ask for take the baby go to home. So because of the permission from the office is finished after 3 months. So we are tapering down the ketamine, and we try to give the drug orally. So the patient goes home, and in the February, 2 February 2024, with valproic acid, levetiracetam, phenytoin oral, diazepam rectal if the patient seizure, and we continue the ketogenic diet. This is a case analysis. The patient is first 3 months of life. This is a video of the patient. Months of life, daily seizure, the spasm, right? This can be long. Patient is can. The epileptic spasm occur in a sleep as well as in a wake state. This is in a sleep. Okay, and this is in a PQ. Okay. Definition. Tractable epilepsy defined as a failure to achieve seizure control despite adequate trial of anti-epileptic drug therapy. The New International League Against Epilepsy consensus definition is drug-resistant epilepsy requires failure of 2 tolerated, recommended to replacing the term intractable with drugs resistance. Epilepsy syndrome is an epileptic seizure accompanied by a collection of clinical signs and symptoms, onset chronicity, as well as typical AEG and imaging, with application of specific etiology, management, and prognosis. OHTAHARA syndrome is a rare form of epilepsy characterized by seizure and developmental delays that usually occur within first 3 months of life, most often within the first 10 days. Some cases are caused by a brain abnormality, metabolic disorder, or gene mutation, while other cases have no known cause. Epidemiology. Intractable epilepsy is incidence and prevalence are uncertain and estimate in the proportion between 20 to 40%. OHTAHARA syndrome incidence has been estimated 1 to 100,000 births in Japan and 1 to 50,000 births in UK. Approximately 100 cases total have been reported, but this may be underestimated. Etiology, OHTAHARA syndrome can result from a variety of etiologies, such as majority of case has been associated with structural brain abnormalities, genetic mutation, metabolic abnormality, even in some case with no structural lesion was evident in cranial imaging. Post-mortem examination demonstrated evidence of a migration disorder or dysgenesis that was not previously appreciated in neuroimaging. So this patient could be caused by genetic mutation because she has a brother with the same complaint. The pathomechanism was there is imbalanced neurotransmitter in brain. There is two ways. One is decrease of neurotransmitter inhibition. So it can cause hyperpolarization and GABA damage occur, and so the epilepsy can happen. So the other side is increase of neurotransmitter inhibition can cause depolarization, increase of influx sodium, and increase of N-methyl aspartate. So it can increase potential egg, so the epilepsy can happen. In OHTAHARA syndrome, there is several genes have since become associated with OHTAHARA syndrome. It can be associated with mutation in ARX and etc. And intractable epilepsy drug resistant epilepsy, the mechanisms are not completely understood. More likely multifarial, factorial. The transporter hypothesis expression of multi-drug efflux transporter causing a decrease of intracerebral drug concentration, suggests alteration of the cellular target of anti-epileptic drug. Pathology demonstrates neuroimaging support of progressive process. Alteration in neural circuit may lead to epileptic network that becomes drug resistant over time. So there is a risk factor in intractable epilepsy. The reference say that intractable when 2 or more trials anticonvulsant fails to control the seizure. But in this patient, we have more than 2 drugs, anti-epileptic drug, phenobarbital, phenytoin, valproate acid, midazolam, levetiracetam, levetiracetam, ketamine, and diazepam. The response to the first anti-epileptic drug and a high number of seizures prior to the diagnosis treatment. So in the reference, the history of receiving drug seizure phenobarbital in BG hospital, and the patient still have a seizure after being given a dose of 8 milligrams per kg. Before treatment, the patient was general seizure duration 4 to 6 hours. Since certain pediatric epilepsy syndrome are almost invariably medically intractable. In this patient with epilepsy syndrome, etosa suspected OHTAHARA syndrome. Syndrome epilepsy is an epileptic seizure accompanied by a collection of clinical signs and symptoms, onset, chronicity, as well as typical EEG and imaging with application of specific etiology, management, and prognosis. Several types of epilepsy syndrome can be found, like early infantile epileptic encephalopathy, like OHTAHARA syndrome, West syndrome, Dravet syndrome, Lennox-Gastaut syndrome, childhood absence epilepsy. This is a clinical symptoms of OHTAHARA syndrome. Both females and males, infant born with may experience symptoms while asleep or awake. First 3 months life. Although birth history and head size in infant is typically normal, microcephaly may occur. Tonic seizure and spasm, muscle stiffness, dilated pupils, diplegia, hemiplegia, tetraplegia, ataxia, and dystonia. Other seizure types that may occur including partial seizure, cluster of infantile spasm, and rarely myoclonic seizure. The red one is present in our patient. The diagnosis is based on the clinical presentation and on typical electroencephalograph pattern based on time of onset. Typically, onset of seizure and spasm have been indicative of OHTAHARA syndrome diagnosis, while MRI and abnormal EEG burst suppression pattern can confirm. Genetic testing with chromosomal microarray analysis followed by an epilepsy gene panel or whole exome sequencing may be considered after MRI imaging has been exhausted. Case analysis. In the clinical symptoms while asleep and awake, microcephaly, partial seizure, cluster of infantile spasm, tonic seizure and spasm, and muscle stiffness. The diagnosis based on clinical presentation and typical electroencephalographic with EEG burst suppression. So the EEG show burst suppression. The recent treatment is anticonvulsant drugs and steroid may be used to try to control the seizure, but their effectiveness is limited. Most therapy are related to the symptoms and day-to-day living. For cases related to focal brain lesion, epilepsy surgery or functional hemispherectomy may be considered. A ketogenic diet may be suggested for reduction of symptoms. Should the child survive past of the age of 3, vagus nerve stimulation can be considered. For the information, the recent condition of this patient, the patient is already free from seizure for 1 month. Thank God. The condition is improving. Thank you. So the next presentation is about the management of refractory seizure. It will be presented by Satoshi Nakagawa.
Thank you very much.
Sorry. Before we begin, I will read the CV of our speaker.
Okay.
Satoshi Nakagawa was graduated from Tohoku University School of Medicine, Sendai, Japan in 1984. From 2021 until now, he is Associated Director of Patient Safety and Quality Improvement National Center for Child Health and Development. He has so many publications and a lecture in many countries. Without further ado, I like to welcome our presenter to start the presentation.
Dr. Aizah, thank you very much for your kind introduction. It is very honor for me to be participating the lecture session at the Hasanuddin University. Thank you very much for the invitation. And today I'd like to talk on the management of the status epilepticus. I hope you can hear my voice and you can see my slides. I'm a pediatric intensivist, not a neurologist, and in the treatment of refractory seizure, we need to work together with the neurologist and the intensivist. So if you have any special questions regarding the neurological issue, although I'm not the specialist, but I try to answer the question at the end. So today I would like to talk on the guidelines of the status epilepticus. And secondly, I would make a comment on the epidemiology of status epilepticus, as well as the super refractory status epilepticus. And in the last, I will make some comments, and I would like to show some important studies on the anti-seizure medications, especially for children. This is the guidelines published by the American Epilepsy Society, published in the 2016, which was almost 8 years ago, but still the contents is relevant to our practice. So this is evidence-based guidelines, treatment of convulsive status epilepticus in children and adults, a report of the guideline committee of the American Epilepsy Society. And this guideline has a very nice algorithm shown here from the initial stabilization to the third line therapies. So I'd like to look at these guidelines in detail. So first of all is the interventions for the emergency department in patient setting or a pre-hospital setting with trained paramedics. So this is 0 to 5 minutes stabilization phase. Number one is stabilize the patient, airway, breathing, circulation, and the disability, neurological exam. Number two is the measure the time seizure from its onset, monitor vital signs. This is the neurology guidelines. However, it is very important to comment on the ABC before giving the anticonvulsant. Number three is assess oxygenation, give oxygen via nasal cannula or mask, constant intubation if refractory assistance needed. Number four is initiate ECG monitoring, not the EEG. So start with the EKG or ECG monitoring. And number five is collect finger stick blood glucose, because sometimes seizure is associated with the hypoglycemia. So if the glucose is below 60 milligram per DL, then give glucose in adults 100 milligram thiamine IV, then 50 ml of DD50 IV. In children greater than 2 years old, 2 ml per kilogram of the D25. We don't have the D25 in Japan, so we use the D20, so 2.5 ml per kilo of D20. Or if the children is younger than 2 years old, 4 ml per kilogram of D12.5, but we don't have the D12.5 in Japan, so we use the D10, so 5 ml per kilo of the D10. And attempt IV access and collect electrolytes, hematology, toxicology screen if applicable, and anticonvulsant drug levels. So this is thorough investigation of the course of the seizure activity on those patients. So after that, the first line, we can start the first line treatment. And benzodiazepine is the initial therapy of choice. This is level A. So there's a strong evidence that using the benzodiazepines in the first line treatment, choose one of the following 3 equivalent first line options with dosing and frequency. So one of those 3 options, number one is intramuscular midazolam, 10 milligram for the adult greater than 40 kilogram. 5 milligram for the children between 13 and 14 kilograms, single dose, level A, or intravenous midazolam, 0.1 milligram per kilogram per dose. Maximum dose is 4 milligram per dose. May repeat one dose once. This is also level A, or intravenous diazepam, 0.15 to 0.2 milligram per kilo per dose. Maximum dose is 10 milligram per dose. May repeat dose once. This is also level A. If none of the three options above are available, choose one of the following: intravenous phenobarbital, or rectal diazepam, or intranasal or buccal midazolam. So this is the first line treatment, and benzodiazepines are recommended. Those are the second line and third line treatment. In the second line treatment, there is no evidence-based preferred second therapy of choice. So this is level U, uncertainty. Choose one of the following second line options and give as a single dose. Either intravenous phosphoenitoin 20 milligram, phenytoin equivalent dose per kilogram, or intravenous valproic acid 40 milligram per kilogram, or intravenous levetiracetam 60 milligram per kilogram. If none of the options above are available, choose one of the following. If not given already, intravenous phenobarbital 50 milligram per kilogram. And if the seizure continues, we can go to the third line treatment. However, there is no clear evidence to guide therapy in this phase. This also level U, uncertainty. Choices includes repeat second line therapy or anesthetic dose, either thiopental, midazolam, pentobarbital, or propofol. So those are the recommendations by the American Epilepsy Society, published in the 2016. And the majority of the institutions are following those guidelines with some modification. So next, I'd like to make a comment on the epidemiology of status epilepticus, as well as the super refractory status epilepticus in children. So this study was done in Germany. This is epileptic status in pediatric cohort, SPED, requiring intensive care treatment, a multi-center national 2-year prospective surveillance study in Germany over 2 years from July 2019 to June 2021. They picked up over 480 patients from Germany over 2 years. And as it is indicated in this graph, the most common cause is prolonged febrile seizure, followed by the infection, sepsis, and metabolic disorder, and incorrect medication, acute lesion injury, sleep deprivation, hypoxia, cardiac arrest, and febrile infection-related epilepsy syndrome, 5 years. And almost 50% of the patient had the generalized seizure, and close to 20% of the patient had the focal seizures. This is among the 481 status epilepticus patient, 119 patients had a repeated episode. So those are the second admission or the third admission or above. So 33 patients had the previous history of the status epilepticus, and the rest of the patients had the more than 2 admissions to the hospital admissions due to status epilepticus. So roughly 20% of the patient, 25%, a quarter of the patient had the repeated episode of the status epilepticus in the series. This is a common medication. Panel A indicates the home medication. So some of the patient had prescribed the diazepam. So diazepam is the number 1 medication, followed by the midazolam. And then panel B indicates the treatment at the ambulance service or emergency physician. So at the emergency department, common medication is midazolam, followed by the diazepam. In the pediatric intensive care unit, common medication is the midazolam in Germany, followed by the levetiracetam, phenobarbital, diazepam, and antipyretic for the fever, and clonazepam, propofol, lorazepam, valproate, and phenytoin in Germany. This is the outcome. The medium modified ranking scale was 1 in medium. 1 means the normal condition. However, at the discharge, the median goes to 2, so mild disability in medium. New neurological deficit after status epilepticus were observed in the 6% of the patient. So some patient had the deteriorated neurological patient, and mortality was 3.5%. 17 patients died eventually. This is another study reported from I think from the United States. This is a study on the super refractory status epilepticus, and definition of super refractory status epilepticus was adopted from the adult definition: continuous or intermittent seizure lasting greater than or equal to 24 hours following continuous infusion initiation. So even though the patient required continuous infusion of the anti-seizure medication, patient may have the continuous or intermittent seizure 24 hours initiation of the after 24 hours initiation of continuous infusion. So they picked up the 281 patients, and among them, the super refractory status epilepticus occurred in the 31 patient. So there's a comparison of the non-super refractory as the super refractory. There's no difference in the age, and there's no difference in the gender. However, the time to the first non-benzodiazepine anti-seizure medication is completely different, and the super refractory patient had the longer duration from the onset to the requirement of the non-benzodiazepine anti-epilepticus anti-seizure medications. Same thing can be said. It is in the time to continuous infusion. Continuous infusion start late in those patients, and the seizure duration was longer in the super refractory status epilepticus patients. Clinical outcome of the super refractory status epilepticus. The first column is the return to baseline function. As you can see, only 22% of the patient returned to the baseline, so rest of the patient did not return to the baseline. So there's a significant morbidity occurred in the super refractory status epilepticus patient. And those patients has the higher medical complications. Almost 60% of them had medical complication. And the length of ICU stay was longer compared to the non-super refractory group. And in hospital mortality is around 13% compared to the 2% in the non-super refractory patient groups. So as you can see, the super refractory status epilepticus patient had the higher mortality and the higher morbidity. And those are the medications those super refractory status patient received. They received continuous infusion of their medicine, and half of the patient resolved the status epilepticus with a single dose of the continuous infusion. However, the 30% of the patient required 2 continuous infusion medicine, and almost 20% of the patient required 3 or more continuous infusion in the series. And the majority of the patients required midazolam continuous infusion. 30 out of 31 patients received midazolam continuous infusion, and 1 patient received pentobarb continuous infusion. Second line continuous infusion medicine was pentobarb in almost 70% of the patient, followed by the ketamine, propofol, and midazolam, and valproic acid. And 6 patients received a third continuous infusion, either ketamine or pentobarbital, and 2 patients received either ketamine or propofol as a fourth continuous infusion. So a super refractory status epilepticus patient, half of them received only 1 continuous infusion medication, however, the rest received 2 or more continuous infusion medications. And besides the continuous infusion medications, some patients received the corticosteroids or ketogenic diets, IVIG, or vagal nerve stimulation, or interleukin-1 receptor antagonist, and the plasmapheresis. Probably they considered the possibility of the autoimmune encephalitis or encephalopathy. That is why they received the corticosteroids or ketogenic diet or IVIG or interleukin-1 receptor antagonist, even with the plasmapheresis. This is what the super refractory status epilepticus patient received the treatment in the United States. So in the last, I will like to make a comments on the recent studies on the anti-seizure medications. Some of the RCTs and observational studies, which were done in the pediatric populations. So as you have already seen in the second line treatment, there's a list of the medication, phosphenitoin and the valproic acid and levetiracetam. So those medications are studied in the RCTs in the pediatric populations. So this is the Eclipse study published in the Lancet in 2019. This is a comparison between the levetiracetam and phenytoin. As you can see, the almost 30% of the patient become seizure-free with the levetiracetam, and compared to the 35 to 40% of the patient become disease-free, seizure-free with phenytoin. However, the difference is not statistically significant. So in conclusion, they say although levetiracetam was not significantly superior to phenytoin, the result together with the previously reported safety profiles and the comparative ease of administration of levetiracetam suggest it could be an appropriate alternative to phenytoin as the first choice, second line anticonvulsant in the treatment of pediatric convulsive status epilepticus. So historically, phenytoin has been commonly used in the second line treatment, but levetiracetam may replace the phenytoin as the second line treatment in their conclusion. In the same issue, on the same issue of the Lancet in 2019, there was another study was published. The study name is Concept. This is similar study comparing the levetiracetam with the phenytoin. They assessed the seizure-free status after the 5 minutes of the infusion of the study drug, and seizure-free was achieved in the 60% in the phenytoin group and 50% in the levetiracetam group. However, when we look at the 2 hours after the treatment, clinical cessation of seizure activity at 2 hours without further seizure management was almost equal in two groups, and received an alternative study drug in the first 2 hours is also equivalent, around 40%. And clinical cessation of seizure activity at 2 hours, receiving only one or both study groups, equivalent 78 to 72%. And the median time to clinical seizure cessation is 22 minutes in phenytoin group and 17 minutes levetiracetam groups. So both medicines are equally effective in this study. In 2020, another study was published on the Lancet. This is a set study group, and they did this study in pediatric patients as well as the adult patient. So top panel indicates the efficacy of the pediatric population, and the proportion with treatment success is around 50% in the three medication, either phosphonitoin, levetiracetam, or the valproic acid. So those three medications are equally effective in pediatric population. However, if you do the breakdown analysis of the patient age group, 0 to 5 years old, 6 to 10 years old, and 11 to 17 years old, effectiveness may differ from medicine to the other medicine. From 0 to 5 years old, all three medications are equally effective, and the phosphonitoin may be superior to the other medication. However, when we look at the older population from 6 to 10 and 11 to 17 years old, valproate may be the most effective medication compared to the other medications, and phosphonitoin may not be effective as in the younger population, in the older population, especially in the 11 to 17 years old. The ketamine is an old medication. However, ketamine is getting popular in the treatment of refractory seizure. There's no RCTs in ketamine. However, this is the study at the Children's Hospital of Philadelphia, CHOP, and they showed the experience on the 69 patients in the series at the Children's Hospital in Philadelphia. Before receiving the anesthetic agent, they have already received the 3 medications in median, and durations of status epilepticus to first anesthetics was half day, 12 hours, and duration status epilepticus onset to ketamine infusion was 20 hours. Now, this is a breakdown of the medication of the 69 patients, and 31 of them initially received midazolam continuous infusion, and 28 of them followed by the ketamine infusion as a second line of the continuous infusion medication. And 3 of them received the midazolam first, and the pentobarbital in the second, and the ketamine in the third. 38 patients received the ketamine as a first-line continuous infusion medication, followed by the midazolam and pentobarbital in 2 patients. Common starting dose was 1 milligram per kilo per hour at the Children's Hospital Philadelphia, and increase up to 2, 3, 4, 5, 6, and 7 milligram per kilogram per dose per hour in the population. So 2 patients received 7 in the maximum, and the 3 patients received 6 in the maximum, and 7% of the patients received 5 milligram, and 13 patients received the 4 milligram. However, the rest of the patient was okay with the 3 milligram in 20% and 2 milligram in 22% and 1 milligram per kilo per hour in almost 30%. So this is what they used in the treatment. 44% of the patient had the terminated seizures, and 23% of the patient reduced seizure burden, and 23% of the patient no effect on seizures by ketamine infusion. So half of the patient, almost half of the patient, had their terminated seizures by the ketamine, and quarter of the patient had the showing the decreased seizure burden by the ketamine infusion. When we have the refractory seizure patient, we usually focus on the anti-seizure medication. However, as I showed the guidelines at the beginning, the general management is very, very important. So not only focusing on the seizure medications, it is very important to stabilize the general conditions, including the airway, breathing, and circulation. At my institution, pediatric ICU, we commonly do use those medications in order to control the refractory seizure. So this is a sequence of anti-seizure medications choice. First is midazolam, a single shot, followed by the fosphenytoin. And then if the seizure does not stop, we usually implement the midazolam continuous infusion. And we may add the levetiracetam intravenous administration. And then we go on the ketamine continuous infusion if this is a refractory seizure. And if we cannot control the seizure activity, we may consider the thiopental continuous infusion. However, with the thiopental continuous infusion, we often encounter the hypotension. So we may need to give the vasopressors to control the blood pressure in those settings. In summary, stabilize ABC and assess D, disability first, and then we can give the anti-seizure medications. Initial treatment should be the benzodiazepines, and with there's a strong evidence to support the benzodiazepines. Second line treatment, unfortunately, there is no strong evidence. So this can be done by the per protocol of each institutions. We usually use the fosphenytoin as a second line. Third line treatment also do not have the strong evidence. So this will be done by the per protocol of each institutions. We commonly use the midazolam continuous infusion as the third line treatment. And if there's no effect, desirable effect by the midazolam infusion, we may go on the levetiracetam IV or the ketamine or barbiturate continuous infusion. As I shown you in the earlier, refractory seizure may have the high mortality and morbidity compared to the easily controlled seizure activities. Thank you very much for your attention, and I'm happy if you have any questions. Thank you very much.
Okay, thank you, Dr. Satoshi. Thank you for a great presentation. Now we'll move to the Q&A session. If there is someone want to ask question, please write in the chat column. This is one question. Satoshi, can neuroprotective drugs such as citicoline be given to patients with status epilepticus as an adjuvant? For how long? Thank you, Prof.
Thank you very much for the questions. Neuroprotective medication may be preferred by the neurologist. So we usually discuss with the neurologists, and if they prefer to use, we may use them. But I think there's no evidence support in the treatment of the status epilepticus on those conditions. So if the patient have the cerebral infarction and develop the status epilepticus, this may be the choice of the consideration, but unfortunately, we don't have the strong evidence to support the neuroprotective medication. Thank you for the question.
Okay, the second question is, you mentioned earlier about the ketogenic diet as a therapy for patients with intractable seizure. Can you explain what is the indication for the ketogenic diet?
I'm not the specialist for the ketogenic diet, so I cannot make the comments in detail. However, when you see the refractory seizure, especially associated with the autoimmune encephalitis or encephalopathy, it is very difficult to control the seizure, and one of the choice for the refractory seizure is the manipulation of metabolism. So based on the experience with the neurologist, some neurologists advocate the use of the ketogenic diet, especially in the refractory seizure. I don't know the exact mechanism of the ketogenic diet, but this may control the metabolism, and this may be contributed the decrease the frequency of the seizure activities in those patient group. And I understand that the patient of the Dr. Aizah, Dr. OHTAHARA syndrome patient also received the ketogenic diet. And I think the seizure frequency was getting less with the ketogenic diet. So maybe become a choice in the refractory seizure patient. Thank you for the question.
Yes, maybe I can add the comment for the ketogenic diet. Yes, this patient has, we give ketogenic diet in this patient. The diet is with a high fat, low carbohydrate, and moderate protein. In this patient, we give ketocal formula milk. We will prescribe by physician but monitored by dietitian. Ketogenic means produce of ketone in the body. The ketone are formed when body use fat as a source of energy. The proportion of the fat is 4, and the proportion of protein and carbohydrate is 1. So this is a high fat diet. So the pathogenesis is unclear, but maybe because this can cause metabolic changes in the blood and cerebrospinal, including the decrease of glucose level and increased mitochondrial function and energy reserve, resulting synapse stabilization, excitatory can be decreased. So I think the pathophysiology is for the ketogenic diet is based on that. But this patient have a good effect when we give the ketogenic diet. The patient is not seizure anymore until the patient sent home. I think this is for the ketogenic diet is for intractable epilepsy. One of the choice, I think. Okay, we proceed to the another question. What are the indication for surgery in epilepsy patient, and what is the post-operative prognosis?
Thank you for the question. So if we have the very difficult to control seizure patient, usually they are not acute phase, in the chronic phase, we must identify the foci to resect. So we need the mapping by the EEG, and we identify the foci of the epileptic foci, and we need to ask the experienced neurosurgeon for the epilepsy surgery to resect the foci. Or the other treatment might be the hemispherectomy, but this should be discussed with the specialized epilepsy surgeon. So this usually do not be applicable in the acute phase, but if the patient continues to have the seizure very frequently in the chronic phase, this should be discussed with the neurosurgery. Thank you for the question.
Okay, thank you. The next question is, what is a long-term side effect should be aware when we administering anti-seizure drugs?
So this is a very important question. Long-term effect is usually the combination of the disease itself as the medication. So if the disease is very severe, as I shown in my talk, the patient may exhibit the long-term sequelae, or the death may occur in the 10% of the patient. However, if we give the multiple medicine as an anti-seizure medication, this also causes the side effect. So as patient consciousness status is completely depressed by those medications. So in the long-term management, we have to make a balance of the side effect of the anticonvulsive agent, as well as the patient general status. So those should be discussed with the neurologist, especially in the long-term consequences. This is very difficult to control. Thank you for the question.
Okay, there is still one question. Some medicine that need to be given in intensive care, such as midazolam or ketamine, what should we monitor if we want to give them to our patient? How important it is to prepare any antidotum or to be prepared for airway management as a side effect of anti-seizure?
This is also a very important question. And in Japan, midazolam continuous infusion is often done by the general pediatrician on the pediatric wards without any monitoring, just monitoring by the pulse oximeter. However, we know that the midazolam may depress the respiratory center, so the patient may have the hypercapnia. So I usually recommend them to transfer the patient to the ICU to do the very intensive monitoring by the pulse oximeter, as well as the arterial line insertion, allow us to measure the blood gas. The patient do not develop the hypercapnia in general. With the ketamine infusion, usually patient is deeply depressed, so our preference is intubate the patient and on the mechanical ventilation with the midazolam infusion and ketamine infusion, and in order to control the ventilation very adequately. So intubation and mechanical ventilation, and the monitoring by the arterial line to measure the continuous blood pressure, as well as we often check the blood gas in order to assure the gas exchange is maintained. As I mentioned in my talk, with the thiopental infusion or pentobarbital infusion, this is a potent depressor of the cardiovascular system. So a patient usually exhibit the hypotension, and the patient require the vasopressors. So almost all the cases, we insert the arterial line to measure the continuous blood pressure monitoring. And if the patient become hypotensive, we start the vasopressors in order to maintain the blood pressure. Those are the monitors what we do. There's no antidote for the overdose, so we have to continue the supportive therapy. Then at the same time, we need to decrease those medications to avoid the further consequences. So there's no good antidote, and we must we must continue the supportive therapy. Thank you for your question.
Okay. There is still one what is the prognosis factor for the seizure? Can the disease be prevented in a perinatal period?
I think this is also a very good question. Some disease may develop in the in utero or the perinatal period. So it is important to prevent the those events. However, it might be very difficult to control the hypoxemia to the fetus brain. So it is very important issue, but still it's very challenging. So I do not know what's the effective way to prevent them. So but it's important for the neonatologist as well as the obstetrician. Thank you for the question.
Are there any criteria for outpatient care for intractable seizure patient, considering that the patient has never previously been treated in regular ward, as well as educating parents about how to anticipate and how to prepare at home? Considering every parent might be very worried and feel unprepared to care for the child with a case like this.
This will be done by the neurologist. So neurologists will discuss the parents, what the current condition is and what can be expected in the long-term consequences. And this should be shared among the physicians and patient family, and they can make a long-term plan for their management. So this is the bottom line. So in that process, usually the intensivist is not involved, and usually the neurologist has a tremendous role to control their long-term management with the family. Thank you for the question.
Okay, for the information, the patient is still came to our hospital for continuing the epileptic drug, and we still contact the neurologist, still contact the pediatrician in the Kolaka. So I think the patient is still in monitoring. The next question: how much we need to use continuous EEG monitoring in PQ in status epileptic patient?
Thank you for the question. This is also an important question. So it depends on the availability of the EEG monitoring machine. Back to 20 years ago or 30 years ago, I was at the conference in the United States, and one of the neurointensivists recommend the continuous EEG monitoring for every seizure patient, because if someone has arrhythmia, we monitor the EKG, right? So the seizure is like arrhythmia of the brain. So if the patient has the seizure, every patient requires EEG monitoring. So this is the bottom line concept. However, the continuous EEG monitoring is not easy. So it depends on the availability. So currently in my ICU, we use the continuous EEG monitoring for the refractory seizure patient. Also, as on the post-resuscitation patient, they may develop the occult non-clinical seizure. So we can apply the continuous EEG monitoring on those patients. But continuous EEG machine is expensive, and that you may not have the multiple units of the machine. So it depends on the availability. But ideally, the refractory seizure patient needs the continuous EEG monitoring. Thank you for the question.
Okay. I have a question. This question from me. You said that we can give propofol in the super refractory seizure, but we're afraid to give propofol because I think it's not safe, because we have to give just only 2 in 2 days. So if you have a 2 drug, and what you choose, this propofol or ketamine?
My choice is ketamine. Propofol is contraindicated in the children, especially the continuous infusion, because children have had the high incidence of the propofol infusion syndrome, and subsequently we saw the death in the pediatric population. So we have to pay attention to the use of propofol in the continuous infusion, especially in the pediatric ICU. So my choice is the ketamine rather than the propofol infusion. However, in some centers with the experience with propofol, they may use, but I personally do not have the rich experience in the propofol use for the refractory seizure. So in general, I do not use it.
Yeah. I read about the tetanus, the epileptic state because of tetanus. The choice is also propofol. We can give ketamine in the epileptic state by tetanus.
I don't know. I have no idea. I'm sorry.
Yeah, because in Indonesia we still have a patient with tetanus.
Oh yeah.
Okay.
We just do the supportive therapy for the tetanus, and if they develop the seizure, we usually use the regular anti-seizure medication. But in tetanus, we continue the supportive therapy. If the patient requires the supportive mechanical ventilation, we just continue. And if the patient has the good spontaneous breathing, we just extubate the patient at the time. If it is allowed.
Yeah. Okay. Is there no more question? So thank you, Dr. Satoshi. Finally, now we have reached the end of this event. I would like to say thank you to the speaker for the great presentation and to the audience for this active participant. Thank you for your attention and have a great day. Maybe we can show that we open the camera so we can photo all the participants.
Dr. Aizah, thank you for your case presentation. It's a very good case, and you managed the patient very well.
Yes, thank you. Thank you, Sensei.
In 3, 1, 2, 3. Okay, next slide. 1, 2, 3. Thank you, Dr.
Okay, thank you, Dr. Satoshi, for being a speaker for today.
Thank you very much.
I am looking forward for the next guest lecture to our residents and other member of the pediatric emergency in Indonesia. Okay.
Thank you.
Maybe we can leave. Okay, maybe we can leave.